Today I'm going to talk about the nervous system. I'm just going to do a basic introduction. Now remember, if you're taking the class, you will have to know a lot more. You will have to deal with the lectures, you'll have to deal with the readings, and you'll have to deal with the labs. Remember, this is just a basic introduction. Hopefully it'll get you what you need to be able to understand the basics of it. The first thing I'm going to talk to you about is the basic structure of the neuron. Now the neuron is a functional unit of the nervous system. And the way we actually will draw it is we have, just like every other cell, phospholipid bilayer. We have a nucleus, which is genetic material. We have cytoskeleton. We'll have cytoskeletons going. We have a mitochondria, and this one has a lot of mitochondria. What that tells you is it has a lot of energy it needs. It needs a lot of sugar, water, oxygen, needs all the nutrients that you need, and it needs it in a right concentration. Too much or too little can end up causing brain damage or nervous tissue damage. So we have all the organelles that are in a cell, any cell, and we also have these receptors up here, just like you would in the, we also have special proteins on the side here. And you have another nerve that comes around and wraps its phospholipid bilayer around this area here. And so what we have is we can see that there are three regions to this. You have these projections off the end of where the nucleus is, which are called your dendrites. We have this area here where the nucleus lives, which is called your cell body or soma. Soma means cell body. And we have this long projection here called the axon. And the axon is covered by a lipid molecule called myelin. And there are these little nodes, which are called axonal nodes, nodes of Ranvier, and they allow certain things to come in and out. Now, usually this myelin acts as an insulation, and it doesn't allow things to leak too well. But in these areas is where it does allow it. If you think of the receptor here, you have a neurotransmitter which binds to it. This actually sounds a lot like endocrine. The reason is it functions a lot like endocrine. So a neurotransmitter binds to the receptor. It causes channels to open. It's usually sodium channels. You have enough sodium channels open that it causes the entire cell to depolarize. And when the entire cell depolarizes, sodium channels open here. You also have potassium channels. So it's pumping 3 sodium out for every 2 potassium. Each one has a positive charge. So you have a negative charge. And when you open up sodium channels, the charge goes to 0. When you open up the potassium channels, charge goes back down, and then you have to use the sodium-potassium ATPase to get this back. In physiology, you'll talk a lot more about this, but there is an area called threshold, and that's how many of these receptors you need to pretty much open to end up getting this thing called an action potential. This is sodium out, potassium in, and you have the sodium-potassium ATPase getting this back to resting. In physiology, you'll talk a lot about resting membrane potential. I'm just want to show you a little bit about this so you understand why and how it's like that. When you have your action potential, it starts here in the axon hilus, and it goes to the axonal nodes here, and comes to the end. At the end, instead of having sodium, it ends up opening calcium channels, which binds to a molecule on the vacuoles called calmodulin, which binds to the phospholipid bilayer and releases neurotransmitters, which can bind to another neuron. And that's how the basic neuron functions. So we have the different areas, we have what everything does. And one of the things I will tell you is most neurons do not look exactly like this. You have 4 different types of neurons. I already talked about this before, but we end up having on the ectoderm, outside, we end up having a fold called the neural fold. And it progresses to go in and in until you have a tube inside. And you have cells that came in on the side called neural crest cells. So this is all ectoderm, and this tube is now in the mesoderm. If we were to finish drawing this out, we would have our ectoderm here, our mesoderm all around, and over here, we'd have the endoderm. Here, tube. So it got 2. About day 20 is when this fold starts to happen and brings it in with the neural tube. You also have the notochord here, which we've talked about, which is mesoderm. And what ends up happening is the tube is going to modify itself, and it's going to end up having a big bulge up at the top, which will be the brain, and the bottom, which will end up being together, which will be the spinal cord. And you have a tube, it started as a tube, so the inside is actually empty. And you have your neural crest cells all along here. What ends up happening is you start making a lot of divisions, and the neural crest cells here end up forming branches to come into the neural tube here. So we end up having branches coming in here. And we have projections here coming off as well. What ends up happening is you see where the cell body is here. These cells are actually going to take messages from the outside, and it's going to bring it into the neural tube. Top one is going to send message to the middle. This one is going to send messages out. And so you have different types of nerves already coming out. So you see an area, a big lump that's going to actually be there, and you see the nerves coming from here out, which are going to send messages. So you have dorsal roots here and ventral roots. And the ventral are going to send messages to the periphery. Dorsal is going to send message from the periphery into the neural tube. As we continue to develop, I'm going to save this brain for later. But what you want to know is you do have a tube down the middle of everything, which is going to be filled with cerebrospinal fluid. One of the neat things is if you don't get enough folic acid for it, you actually won't form this way, and you can end up having spinal cord damages. Now, when this all develops, you have your brain up on top, you have your spinal cord coming off of it, and you have bone around it. And what you need is a pad to protect your brain and your spinal cord from getting hit with a bone. Now, that pad is called the meninges. The pad is called the meninges. And the reason I'm writing this here is because touching the brain or spinal cord, the meninges has 3 layers. You have the pia, the arachnoid, and the dura, and then the skull. So you have the skull, the meningeal pad, pia, arachnoid, dura, and then the skull. Now the pia is touching the brain or spinal cord directly. The arachnoid has all these fibers, and this is usually where you find your blood vessels, is in the arachnoid spaces. And the dura is a hard layer around that. So this is actually what protects your brain from slamming against the skull, and also protects your vertebrae from slamming against different things. Works great until we're going through high velocity or blunt trauma. Now, going back to the spinal cord, always go back and remember your bones. So you have the cervical region, sacral, and coccyx. If you remember your cervical bones, you have 7. Nerves, you have 8 cervical nerves. Thoracic, it's 12 bones, 12 pairs of nerves. Lumbar, 5 nerves. And sacral, you have 5 fused, 5 nerves here. Coccyx, they are fused, but you just have 1-on-1 pairs. And so all these nerves are paired. When you're looking at the spinal cord, what you notice is in the cervical area, you have a big area which is kind of bulging, which we call, you then have a drop, and the 8 nerves are going to be coming off on this area here. In the thoracic region, again, you have a long spinal cord. And then in lumbar, you go to about L1, L2, and that L1, L2, lumbar 1 and 2, you end up getting a bunch of hairs coming off. And that's really important because, and this is going to go down and form, they're going to look like a horse's tail, so we call it cauda equina. We do have a conus medullaris, which would be around there. L2. The reason this area is important is about L4, L5, that's where they put the needle for a spinal tap. The reason they do that is they know that you're safe from the spinal cord, will prevent most damage. The other thing is there's a nice anatomical landmark that leads you to this, and that's the iliac crest. If you find the iliac crest and go medial to the back, you'll end up finding L4, L5, and you know it's safe to do a lumbar puncture there. Besides this, one of the neat things that happens is what they call dermatomes. Dermatomes are going to affect everything but the face. The face is going to have some cranial nerves, usually cranial nerve 5 or 7. And so we're going to start with C2, 3, which is going to be the top of your head. As you go to the back, you have back of the head, C2 to 3. When you get to the neck, you have C2. Get to the lower neck, C3. As you get to the area of the clavicle, if you drew a line through the clavicle, you'd have C4, C5. Your arms and legs would have C6, 7, 8, and T2. T1 is in the front of the arms. T3 would be in the back. And you actually can follow the vertebral levels based on that. And I'm not going to go more than that on the dermatomes. The other thing that's important is if we took the spinal cord and we did a cross section of it. So what we're doing is over here, we're taking a piece. We'll do a piece over here. And we're going to move it around so it's here. What you'd see is you have white matter, which has myelin, and gray matter, which isn't as thick with myelin. You also have a tube there, which is a central canal, which was, when in development, what ended up being there. And you have a couple bumps here, gracialis and cuneiformis. This area in the back here is called the dorsal column. This here is the ventral column, the lateral columns. Now the horns here, you have the dorsal horn. So this is dorsal, this is ventral, this is the ventral horn. We have our gray matter. Outside we have our white matter. And like you remember, you had the big balls that came in, which were called the neural crest cells, which ended up attaching to the spinal cord from tissue. So you have the dendrites over here in some sort of target tissue, and it's going to come up here to this area where you have somas, which is called the dorsal root ganglion. This area here is your dorsal roots, and you also have ventral roots coming off here, which are going to send axons to a target tissue. Usually what ends up happening is you have messages coming down from the spinal cord, areas here and here. This would be somatosensory, this would be somatomotor. Then you have a visceral area right after it. So these two coming in here are going to be visceral. So if you think about it, it does make sense with the body arrangement. Usually sensation will come into the spine, come into the spinal cord here, branch, and you have another neuron which is going to take the message to wherever, to the other side, and take it to the brain. The motor is going to get messages coming down, and it's going to get a message from a neuron, and it's going to send the message back out. Now, the reason these are important is you have a message coming in this way to another neuron, which is going to send the message somewhere else. And it can also, though, send the message here. This message is, as its motor, this neuron here is getting messages from the brain coming down to the spinal cord and sending the message out. Now, what you're seeing here already is this. You have a connection between the messages coming into the body and the ones coming out. And this is actually your arc reflex. So if you feel pain here, it's going to come around, send the sensation to the neuron, and send the message back. So you move before the message gets to your brain. That's pretty much the basics of the arc reflex. The first plexus that I'm going to talk about is called the cervical plexus. The cervical plexus is, just as the name implies, in the neck. And it's made up of roots C1, C2, C3, C4, and C5. And it makes a collection of nerves. Now, the two things I really want you to know, for me, would be the donsa cervicalis, which pretty much is made up of C1, 2, and 3, and it branches to give thyro and hyoid muscles. So the sternohyoid is one of them. You also have the sternothyroid, you have the omohyoid, you have the thyrohyoid, and the glenohyoid. And these are the muscles that are going to be innervated by the donsa cervicalis. The other nerve that's really important for people to know is coming off from C3, C4, and C5. And it's a big nerve that goes from the cervical plexus all the way to the diaphragm, called the phrenic nerve. Now, the reason that's an important nerve is if you actually get damage in this area of the spinal cord, you can sever some of this phrenic nerve, and that can end up leading to a lack of breathing. Now, remember, the diaphragm is striated skeletal muscle, and that's why this area is so important. You do have a lot of other nerves that come off of that. Most of those are involved in sensation. We'll leave it at that. Now, the next thing that I want you to know, which is really important, is called the brachial plexus. Based on the name, brachial, it tells you that it's going to go to the arm. And so we're going to be dealing with a lot of arm things with this. And so this is actually starts from the roots of C5, C6, C7, C8, and T1. And these are going to be the roots that form the brachial plexus. This is going to be going to your arm. Now, remember anatomical position, because it'll tell you where everything's going to go. As we start with the roots, C5 and 6 come together to form a trunk. C7 will form its own trunk. C8 and T1, the roots there, will form a trunk here. Now, as we have three trunks, we can call this one up here superior, this one in here middle, and this one here will be your inferior trunks. These are your trunks. Superior, middle, and inferior. What ends up happening next is we have these trunks divide. We then have division. You can have a posterior. This one will come here, making a posterior trunk there. This one will make a posterior here, and this one will end up making a posterior coming up this way. Now, as all three of these are posterior, this is a posterior chord. And this one is going to this one's going to divide into two. So you have one here, one here. And so this is going to be anterior, but as it's going to be on the lateral side of the arm, if you think about it just following the arm, this will be the lateral chord. On the other side, here, this divides and gives you the medial chord. Now, the reason it's called the medial chord, again, is remember, it's on the medial side. The posterior chord will end up splitting and giving you two nerves. One of them is going to be the radial. The other one is going to be known as the axillary. So the radial is going to go posterior. So if you take your arm, your radial nerve is going to travel the posterior aspect of your arm, and it's going to be involved in the extension of things in your arm. The axillary will go into pretty much the deltoid and armpit area, and you're going to end up getting some of the rotations there. The lateral cord will end up splitting, and you're going to have one nerve go one side, and it's going to end up having another branch here. Now, the medial is also going to do the same thing. And these nerves are going to have names too. This one up here is going to be your musculocutaneous. This one here, your median. And this one here will be your ulna. And you can tell what's going to follow what. So the radius will follow the radial bones, namely on the posterior side. The ulnar nerve will follow the ulna on the anterior side. The median nerve is going to go in the middle of the forearm, usually innervating the anterior lateral sides. Now, there are a lot of other nerves that you can have come off of here. You have the lateral pectoral nerves, you have the subscapular nerves. Posterior cord, you have one nerve that comes off, which is called your long thoracic. And it's important because it innervates the serratus anterior, and if it's damaged, you can end up having a winged scapular syndrome. The other plexus that's important for everyone to know is known as the lumbar plexus. And it's made up of neurons from T12, L1, L2, L3, L4, L5. Now, these are going to come together and form different nerves. But the two biggest nerves that I want you to know, one of them is going to have roots from L2, L3, L4, and L5, and it starts posterior, but it's going to end up forming the femoral nerve. The other one is an anterior division of this, which is called your obturator nerve. This is posterior, anterior. This, from the same nerves, is your obturator nerve. Now you have a lot of other nerves. These are the ones I really want you to know before you actually even get into class. The next plexus is known as your sacral plexus, and your sacral plexus starts at L4, L5, S1, S2, S3, S4, S5, and coccyx number 1. Now the big one that I want you to know is going to have roots coming down from the L4, roots in L5. You're going to have roots from S1, S4, S3, S2. And these are all going to come together to form a major nerve of the sacral plexus. And that nerve is called your sciatic nerve. So sciatic nerve will branch into two nerves. One of them will be the common fibular and the tibial. The tibial will follow the tibia. The common fibular will have two branches, one which is deep and one which will be the superficial fibular nerve. There are a lot of other smaller branches, and those are actually the biggest nerves I want you to pay attention to.